Thank you so much. Okay, so I thought I'd start by one of the great debaters in this country, Abraham Lincoln, and one of the famous quotes that he has, you can fool all the people some of the time, and some of the people all the time, but you cannot fool all the people all the time. So with that in mind, on December 11, 2015, I was extremely honored to get this invite, which was inviting me to debate the role of carcinoid or everolimus in carcinoid treatments. And so, of course, on December 11, 2015, I said, awesome, the great debates have an awesome reputation. I'm finally making my debut, which was great, except then February 26, 2016, the FDA approves the indication for everolimus for GI neuroendocrine tumors. And now I have to mentor I have to debate one of my greatest mentors about this very subject. So I'm still here, and we've done this before. We have a great group of people in the neuroendocrine community, and we've had these debates. So with that in mind, I'm going to debate the following. So as clinicians, we have this Hippocratic oath, which is first do no harm. And I think I'm hoping that that's a recurrent theme on it's about quality and quantity in all of our patients when we're treating for palliation. And I think no other case is that so true in the world of neuroendocrine tumors, where our patients can live for years and sometimes decades. So many of them will do well in spite of us, and we have to be extremely careful of when we're using these therapies. So can you do harm in a debate? Just of note, you cannot blame Dr. Yao that Mr. Cruz is from his home state, because the other guy is from my home state, and I am not taking credit for that one. So for the Europeans in the room, we believe this is a circus, so please don't criticize us for everything that's going on in this country right now. Okay, so what do we mean by first do no harm? So again, many of our patients are going to do well for a long time. Quality and quantity is important, and again, it's also if you treat is not the case, it's when you treat. Almost all of our patients, when they get to our clinic as medical oncologists, will require some therapy at some point, although not all. So again, timing of treatment and when you pull the trigger on all these different therapies is critically important. And that's what I'm going to try to teach you today. So is everolimus going to give us quality and quantity? So we have several different therapies and several different treatment options for patients with neuroendocrine tumors. We use surgery, we use regional directed therapies, and we have several medical treatments. And it gets pretty complicated to decide when do you use what and how, and I can't really do that in this short 12-minute debate. But I'm going to try to explain a little bit for the role of carcinoid treatments in the medical setting. So what about somatostatin analogs? These are obviously the oldest that we have. So the PROMID study was the first time to sort of prove to us in a prospective fashion that in fact somatostatin analogs, this is octreotide in mid-gut tumors, does put the brakes on the disease. So it stabilizes the cancer, right? So everyone knows this data. But octreotide in mid-gut tumors was the experimental arm. It was randomized. Patients received either octreotide or placebo. It was a very well-designed study. And unquestionably, the progression, or the time here to progression was prolonged. On the experimental arm, it took about 14 months for the patients on the octreotide arm to progress versus 6 months. And again, we kind of knew this for a really long time, but it was a really well-designed study that for the first time showed us that, yeah, in a prospective fashion, it does slow down the rate of tumor growth. Then CLARINET came along, and as Dr. Yao explained, these are patients with essentially stable disease, unlike the PROMID, which was essentially patients naive. But CLARINET included more neuroendocrine tumors, including pancreatic neuroendocrine tumors. And they included patients, again, with well-differentiated or moderately differentiated, so G1 or G2, stable disease. We really selected out good biology. And then again, in a prospective fashion, we randomized them to receive lanreotide versus essentially placebo. Lanreotide and octreotide are the exact same biochemical formulation. One is sub-Q, the other one is IM. One is a lot more expensive than the other, but essentially they are very similar. But CLARINET study included all different types of neuroendocrine tumors, and in fact, again, the curves beautifully separate, showing us that the somatostatin analog lanreotide does sort of prolong the progression-free survival. There's a couple of things I love to point out on this slide. The placebo arm PFS was 18 months. So again, Many of our patients are going to do well in spite of us. We need to really clearly define who we're going to treat and when we're going to treat them. If a placebo arm is 18 months. But again, at 2 years, the patients still had not met PFS in the experimental arm, showing very nicely that the lanreotide can prolong progression-free survival in this patient population. So should somatostatin analogs be first line? This is a therapy that's once a month. Many of us know these drugs very, very well. They're very well tolerated. Quantity and quality, this is a good one to consider. I don't have data to tell you in sequencing which has to be done by evidence, but this is a good one to consider as a sort of first string player because they do prolong progression-free survival with very well tolerated side effects. So what about anything else before we get into the everolimus data? Do we consider anything else when it comes to the carcinoid for treatment? So NETTER-1, Dr. Yao alluded to, and I'm going to discuss very briefly. So this was a study in a randomized setting that was just recently reported and essentially took patients that had progressed on octreotide within 3 years. So it's not stable disease. So now we're getting a little bit more defined on, okay, these are going to be patients that probably need some treatment. You can debate 3 years of progression is still pretty slow, but nevertheless, that's the way the trial was sort of stratified. And they randomized patients to receive lutetium-177 dotatate, or Lutathera is known, versus high-dose octreotide at 60 milligrams. And the curve separated beautifully. So these patients, essentially the high-dose octreotide, which is 60 milligrams, had a median PFS of 8.4 months, versus, again, at 2 years, the median PFS was not yet reached, and those curves are clearly very different. This was in mid-gut carcinoid, so again, very exciting in that after somatostatin analogs, until then, we really didn't have great treatments. Overall survival is still way too early, but at least an early look is very exciting that the interim analysis suggests that at least early on the curves are separating. And then even when you look at response rates, so traditionally in carcinoid tumors, we just don't get those tumors to shrink. But in fact, with the NETTER-1 trial, the radiolabeled octreotide had an 18% response rate by RECIST criteria, which is, again, very exciting and one of the biggest response rates that we've had to date in a randomized trial for carcinoid tumors. So that sounds all amazing, which is great. What about the side effects? And again, I'm going back to my theme of first do no harm. The problem with this is that we really don't have great long-term side effect in a prospective fashion to know. And again, these are patients that are going to live for years. So when you look at the hematologic side effects, that's the concern. So you can see thrombocytopenia, lymphopenia, and lowering of the blood counts. Now it's early, and these were not very impressive, but the problem is we want to make sure that we use all of our cards for these patients, and so we really don't know where to put these therapies in and in what order, because we don't want to, for example, preclude a therapy later on when these patients progress because their counts are too low. So we don't have great data to really clearly define that yet, but this is certainly one of our treatment options that will soon be used, and we're very excited about it, but with caution because of the potential longer-term serious blood side effects, or hematologic, I should say. So back to the question, what is the everolimus data to support its role in all carcinoid, and more importantly, are all carcinoid tumors the same? So Dr. Yao alluded to this before. Not every one of our patients, in fact, most of our carcinoid patients are non-functional or non-hormone secreting, but many are. And so for the patients that are in midgut, so midgut carcinoids are the ones that typically have the symptoms, but generally speaking, across the board for all carcinoids, it's probably about 15 to 20% of patients that have the carcinoid syndrome. So what's the role of everolimus in patients with carcinoid syndrome, which is essentially radiant 2? So in about 15 to 20% of those patients, maybe more, but probably not a lot more, the radiant 2 patients were randomized to receive everolimus plus octreotide versus placebo plus octreotide. It was a negative study. So there was predefined statistical boundaries that were made, as all of us do as clinical investigators, and the primary endpoint by central review was not met. If you looked at the overall survival, with the many, many caveats that Dr. Yao explained, the overall survival suggested that the placebo arm was favored. So back to first do no harm, RADIANT-2, overall survival, the placebo arm looked better. That is not something that we want to consider. So in summary, for RADIANT-2 functional carcinoid, the study was negative. It did not meet its primary endpoint, and the overall survival favored the placebo arm. In addition to that, we know everolimus, most of us in this audience. It's not without its side effects. About 2/3 of patients get stomatitis. Now you can say, well, sometimes it's not that bad, but these are chronic therapies, and again, these patients can be on them for a long time. So we have to be careful on the fatigue, the rash, which is not so bad, but the mouth sores can be an issue, and then the more rare but serious pneumonitis is also an issue to consider. So does this data make you want to give the therapy for all carcinoid patients? So I've been in many, many, many conversations with Dr. Yao. So I get to cheat because I know exactly what he always says about the caveats of the RADIANT-2. So, well, there were more lung patients in the placebo arm, as he showed, but RADIANT-4 shows that it's supposed to be active in lung, right? So does that really make a difference? And yes, there was more chemotherapy, but again, RADIANT-4, they had more chemotherapy. And then he always talks about this informative consensory, and I have no idea what informative sensory really is. But there were all these problems with RADIANT-2, but it was negative. So was RADIANT-4 negative? No, RADIANT-4 was positive, and RADIANT-4 had real progressive patients. And this study, even though I'm not supposed to say, it was a beautiful study because it's treating the patients we should be treating. Patients with progressive disease within 6 months, they're not on other therapies, they need a good idea. And that's what they did. They took the patients, or we, because I was part of the study, took the patients, we randomized them to everolimus versus placebo, and the curve separated beautifully. We didn't allow for crossover, we didn't allow for octreotide. It was sequential therapy of when patients generally progress on octreotide, what can we do? And when we give them everolimus, in non-functional patients, the progression-free survival was improved. So 11 months versus 3.9 months. So does everolimus play a role in carcinoid tumors? Sometimes. I think not in non-progressing patients. In patients that are stable, we do not need to give them a therapy just because. Not in patients with high grade. All of these patients were essentially G1 or G2. But in G1, G2, well-differentiated carcinoids, the RADIANT-2 study by statistical design was negative. So we have to think very carefully in a functional tumor, do we need to give the everolimus, or should we be giving that? I think RADIANT-4 unquestionably was positive. They did not combine it with a somatostatin analog, so many people say, do you have to keep on the somatostatin analog? RADIANT-4 says no. Again, these patients had real progressive disease, 6 months progression prior to enrollment. And then again, it's noted that nets are quite heterogeneous. Not all of them respond. The objective response rates are low. We have to consider quality of life, and we have to consider, more importantly, sequencing of therapy and how to do that. And so lastly, it takes a team approach for rare diseases. Thank you.